Good morning, good afternoon, good evening. It is my pleasure to present this session, the session number 2. Welcome to the training on leverage South-South and triangular cooperation, inclusive and technological innovations for urban health and disaster risk reduction. This training will be primarily in English, but we'll have simultaneous interpretation in Arabic, Chinese, French, Portuguese, Russian, Spanish, and also international sign language. Please, you can select the globe icon at the bottom of the screen to select the language of your preference, and it will be broadcasted directly to you. It is important to mention that it is a joint certificate program co-organized by the United Nations Office for Disaster Risk Reduction, UNDRR, the Global Education Training Institute, UNDRR-Getty, and jointly with the United Nations Office for South-South Cooperation, UNOSSC, and glad to present this session on behalf of the Pan American Health Organization, PAHO WHO. We already have 900 participants, and we will proceed with our session as mentioned. As you know, it is important also to highlight that the certificate of participation will be given only to participants who first attend all the 3 training sessions in live and also complete a post-course survey that will be sent at the end of the session 3. Please note that the live training session has a capacity limit to 1,000 participants on a first-come, first-served basis, and we already have reached that number. I like to emphasize that the session attendance is captured automatically when participants access the session using the link sent from Zoom to their register's emails. Please do not use any other links as your attendance may be missed if you are using other links aside from the one sent to your email that you registered before. Also, I'd like to let you know that the post-course survey link will be announced later at the end of session 3. For today's session, as I mentioned, this is the second session of a 3-week training program. The session 2 today will be focused on early and disability-inclusive urban health emergencies and disaster risk management. I want to thank also our colleagues from UNDRR and UNOSSC, but especially our PAHO colleagues from the different departments that we are today participating. As you saw in session, we are using Slido for interaction. So please take out your phones, open your browser, and go to slido.com. And the hashtag is session 2. Is the key code to enter, or you can directly scan with your mobile device directly and it will take you to the Slido interaction. We are today we are interacting through Slido, so please also type your answers in the Q&A section in the Slido box. We'll have also a small interaction following this presentation, so please I encourage you to please go to Slido since we are gonna have a small survey. This is what you are gonna see in your screen, side for Q&A, and the other that will be for the questions that will be presented in the end as a quiz. So please help us join slido.com. Please scan this QR and tell us which country are you with us from today. Where are you joining us from today in this session? And we have already 52 people interacting from Philippines, Mexico, USA, UK, Thailand, Italy, Ecuador, Hungary, Sierra Leone, Uruguay, Switzerland, Hong Kong, Brazil, London, Egypt, Germany, Dominican Republic, Nicaragua, the Gambia. We have people also joining from Nepal, from Ethiopia, from Ukraine, Turkey, Mozambique, Peru, Ecuador, a lot of people from Philippines, from China, from India, from Madagascar, from Malaysia, from Burkina Faso, from Yemen. This is one of the richness of this session. We have, last session we had participants from over 100 countries. So thank you for continuing in this interaction with us. We have over 295 people. We would like to reach out until 500, please. All the participants kindly join us in slido.com, directly scanning your QR code with your mobile phones. Perfect. So in the matter of time, I'd like to mention that we are really honored. We are really happy to have this excellent high-level panel here. We have panelists from all over the world with high experience on this focus, on this session's focus that will be regarding building resilient and inclusive cities, especially addressing health emergencies and disaster risks for the older people and persons with disabilities. We'll have 4 segments in this session. Opening remarks, we'll have the part 1, addressing health emergencies and disaster risk for older people, that will be moderated by Dr. Enrique Vega. He's the unit chief for Life Towards Health Systems and Services at PAHO WHO. In the part 2, focus on critical infrastructure in cities, resilient hospitals to health emergencies and disasters, that will be moderated by my esteemed colleague, Marcy Rode, Executive Director of the World Institute on Disabilities. I'm glad also to host this session with my colleague, Maria Urbina, the Country Program Advisor in PAHO Headquarters WHO. So to start with the opening remarks, I'd like to give the floor to Dr. Ciro Ugarte, Director of Health Emergencies Department in the Pan American Health Organization. Over to you, Dr. Ugarte.
Thank you, Alex. It's a great pleasure for me to join you in this very important session. Good morning, good afternoon, and good night to all of you. Really, it's an honor for me to welcome you to this session of the Joint Certificate Training Program 2025, organized by PAHO WHO, the UNDRR, and UNOSSC. I thank our colleagues, particularly our colleagues who organized this session, for the good effort that they did. Also our panelists. You will enjoy their presentations, and please feel free to ask any question that you would like to, because this is a session when we can answer the difficult questions, but also look for answers for the ones that we don't have yet. And health emergencies and disasters, unfortunately, disproportionately affect vulnerable populations, especially in this case, people with disabilities and the elderly. So currently, organizations are facing several global issues and challenges. The growing urbanization and population aging is increasing in almost all countries. And this increase also is coupled with the extreme weather events and health emergencies. As you know very well, there are many biological threats that can cause pandemics, epidemics, and also the resurgence of communicable diseases that were under control in the past. We have many examples, and you can see the news, but also all the reports of WHO and PAHO in that regards. And also the gaps in response preparedness and recovery, particularly after COVID-19, when before that we thought that we were well prepared and we can respond to any emergency in many countries. Even the measurement of the capacity of the countries was very high, but the pandemic showed us that we are still far from being fully prepared, and this is part of this work. And to address these challenges, it is essential to integrate disaster risk into health and aging policies and ensure that critical health infrastructure are operational, are safe, and are accessible to the people in conditions of vulnerability. In health emergencies and disasters, as you know very well, health facilities and hospitals must continue operating. And that is the purpose of looking at all the standards, the criteria, the building codes, and the operations to ensure that these health facilities are serving the people when the people is needing the most these health services. But this can be only done, as Alex mentioned, in close collaboration between member states, between countries, between organizations, between institutions, between people and disciplines that are linked to health emergencies and disasters, and looking also to strengthen what we call resilience. Resilience is a word that many people are talking about, but the actual resilience that has been in the Americas at least, but also for WHO for many years, and the Safe Hospitals Initiative, and now the Smart Hospitals Initiative, that is safe and green, are actually the way of going, and many countries in the Caribbean particularly, but also in the small island development states are showing the way that we can do that. So we cannot continue to be reactive, but we must prepare, we must adopt and adapt new policies and ensure that no one is left behind, as we many times say. So I invite you to actively participate in this session and welcome you all. Thank you so much.
Thank you, Dr. Ugarte, for this inspiring welcoming remarks. Now I'd like to move and give the floor to start the part one of this session addressing health emergencies and disaster risk for older people. This session will be led and moderated by Dr. Enrique Vega, the Unit Chief of Life Course Health Systems and Services in PAHO headquarters. Over to you, Enrique, and thank you so much for joining us.
Muchas gracias. Voy a hablar en español para
Thank you
dar un
very
poco
much. I will speak in Spanish to change things up a little bit.
Aprovechando la oportunidad que los organizadores
And
nos
also
brindan de tener traducción
to
a
take
todos
advantage
los
of this
oficiales
opportunity since we have
institucionales
simultaneous
reunidas.
interpretation
Muchas
available.
gracias a los organizadores por la inclusión
Thank you
de
to
este
organizers
tema, por inclusión
for
las personas mayores
organizing this session
como una prioridad en
and
el manejo
understanding
de
older
las
people as a
emergencias
priority in
en el mundo
emergency
contemporáneo.
risk management in the modern
Quiero
world.
agradecer también por haberme
I would like to thank you all too for allowing me to moderate this distinguished panel of experts, panelists who are joining here today and whom I have the pleasure of introducing for the first time. Number one, we have Dr. Qudsia Huda. She's the head of the Disaster Risk Management and Resilience Program in our headquarters in Geneva. Then we have Ambassador Luis Gallegos Chiriboga. He's the chair of the Global Initiative for Aging. It's known as GIA in Spanish. We're also joined by Monica Schoch-Spana. She's the director of the Community Health Degree Program in the Texas A&M University. Thank you all for being here today with us. And just a kind reminder, please be aware of the time so that we have enough time for questions and comments later on. Without further ado, I would now like to give the floor to Dr. Huda, who will talk to us about how to manage disaster risks in emergency situations without leaving anyone behind. Dr. Huda, go ahead.
Thank you very much. Thank you, Dr. Vega. So I would like to now share my presentation. I have prepared a couple of slides to make my talk today. So I just want to make sure first that if all of you are seeing my slides, is that okay? Okay. So thank you once again. Thank you for giving me this opportunity to speak at this auspicious forum. And then this is a very, very important topic this session is going to discuss. As disasters become more frequent and intense, it is crucial to prioritize the safety and well-being of older adults. They are one of the core component of the community and most vulnerable. As Dr. Ciro just mentioned, that emergency and disaster disproportionately affect most vulnerable population as the elderly population. So that's more the reason that it's very important to think about this elderly population, think about their challenges, think about their situation, and design everything accordingly to manage emergency and disaster risk. So basically, older individuals, they have their different unique challenges, such as mobility limitations, chronic health condition, risk of acute conditions, social isolation, which can hinder their ability to quickly respond to emergencies and disaster. I mean, I would put it in a broader perspective, because as you are aware that all the charters of the UN and all the United Nations and WHO and a lot of other forums, it is highlighted that right-based approach is key. And when we say right-based approach, it means leaving no one behind. So when we say leaving no one behind, actually it is no one, including our elderly population. We are actually now at a very interesting time. UN Decade of Healthy Aging, 2015 to 2030. So you can understand that this 15 years of span was dedicated just to address those challenges and just to look into the opportunities so that we can design our emergency preparedness and response accordingly. So in view of the UN Decade of Healthy Aging, WHO World Health Organization also developed their strategy around the healthy aging, just to make sure that all the preparedness plan for emergencies and disasters are tailored according to the unique challenges this cohort is facing. And then all the communications are accessible to them. And last but not the least, the support system, the community support system is developed around this. So with this, I would like to highlight on a couple of issues. When we say leaving no one behind, what does that actually mean? This is basically to ensure that all the people, especially the most vulnerable, and when we say most vulnerable, the older population are one of the most vulnerable in the community. They should be included in the planning, implementation, monitoring, and promoting a human rights-based approach, prioritizing the needs of marginalized groups. And then with this charter, like with this broader sense, it's very, very critical to note where we are and where we are going to focus. The reason I'm highlighting the policy and then broader issues globally, because this session, my co-speakers, very esteemed and experts, they are going to talk more about the granularity of this approach. So the whole issue around the elderly population needs to be seen from that perspective, that these individuals have equal access, equal right to all the information, resources, opportunities that a disaster preparedness and response efforts in any countries, regardless of the geographic boundary, can offer to the population. If you look into the Sustainable Development Goals, this issue is actually central. It emphasizes that efforts should be inclusive and reach all people, regardless of their background, location, or vulnerability. Vulnerability is a word that we use in the international communications in the disaster risk management spectrum to highlight all the indicators, all the determinants that would make a population vulnerable. And as I just mentioned, and if you will hear more with from my co-speakers, that one of the vulnerability of the population is like, getting old age. There is a saying that in our part of the world, it says that the elderly population are actually the storyteller. And then this story, they build over the legacy from where we can learn a lot. I'll come to that at the end of my presentation again. So going back to the policy action, that if you see that the Sustainable Development Goals, SDG 1, 2, SDG 11, they are all talking about few indicators like poverty, hunger, sustainable cities and communities, which are completely aligned to the theme and to the ideas and then spirit of this training program. So that's a reason I thought that it's very important to highlight and allude to that what we are discussing today are completely linked to all these sustainable development goals. And sustainable development goal can only be achieved when we consider and we can manage the emergencies and disaster risks, which are often concurrent as well. So why we are talking about the leaving no one behind issues, why you are bringing it up? We are bringing it up to address those inequalities and vulnerabilities. I'm just reiterating it again and again. So coming back here, that when we talk about the inequalities and vulnerabilities, it is pretty much important to look into why we are saying that. So this is where our disaster landscape is. The world looks like it, but I mean, the green thing, I'm actually using it to reflect the natural events, and the red ones have conflict and crisis. However, this is an entirely conceptual slide just to give an understanding. So it's not based on real data plotting as per se. So when we have natural events and societal crises, we also have climate crisis, like all these crises impacted by climate. We have epidemics, outbreaks. We have biological, chemical, radiological, and nuclear threats, food insecurity. And then all these situations contribute one of the major issues, which is population movement. Currently, we are sitting in the world where almost like around millions, I would say that like around 70 million people are actually nowhere, meaning they're displaced. So in that situation, when we consider the elderly population, we also need to consider the context where they are located. That's why these things are very important. And then the pandemic actually hit the world against all these existing risks. And then that contributed to morbidity, mortality, health service disruption. You have heard from Dr. Ciro, health facilities, and you will see that this session is also designed to address some of the other issues. Why I'm saying that? If you look on the list on the right side, from morbidity to supply chain affected, all this precursor needs to integrate the challenges that, and also for the opportunities to protect and safeguard the elderly population. So now I would like to show you this slide as well, that there is another perspective, that when we consider the disaster and emergency risk, we are not talking about one disaster or one emergency risk. Risks are often concurrent. So we have seen it. These are like, few things that I put together, which happened, the events happened during the pandemic time. So when we had the pandemic threat, we also had a lot of natural events and also protracted crises. So when we consider the elderly population, it's very, very important that we think about all these situations. And that's when we think about the solution to that as well, and any intervention. So, I mean, in this perspective, when our landscape is rather broad, interconnected risk and interconnected emergencies, concurrent emergencies, nature of emergencies from different perspectives, it is equally important to focus here. That's because of such complexity, it's very, very important to answer this question. Who is responsible to safeguard? And when we say who, we don't actually point out to a term like, special or like, health sector or any other specific sector. If you see the interconnected risk nature, you should also think about the interconnectedness and interdependency of the system that are working around it, starting from the community, then national level and international level. There are a lot of mechanisms. They are all working together to address the risk and then address the challenges of the communities, and let alone to speak about the elderly population. If you look at the sector on the right side, you would see that all the sectors are interconnected. Preparedness, response, recovery, these are actually sort of like moving phases of any disaster risk management, which touch base all the sectors. So addressing the vulnerabilities is responsibility of everybody. Because when you look into the sustainable development goals, these sustainable development goals are also interdependent. Health is nothing if the nutrition is not addressed. Health is nothing if the education and if other poverty, these are not being addressed, because that's the essence of the whole thing, that these are all interdependent. That's the reason it's not a responsibility of a particular sector to address this issue, but whole of society, whole of governance. I would like to also show that from where the policy comes and then how we can translate it into action. Many of you are aware about the Sendai framework for disaster risk reduction. Then we have these international health regulations. Addressing the challenges of elderly population is one of the key issue discussed under the Sendai framework for disaster risk reduction. In WHO, taking that essence and looking into the international health regulations, we have developed the Health Emergency Disaster Risk Management Framework, which addresses this issue at the same time. And the little tiny thing, as you see at the bottom, the glossary, this is something to explain what is what, how we define this situation, how we use our terminology, how we define and design our actions as well. So this policy is actually impacting prevention, preparedness, readiness, response, and recovery, all the phases of risk management. And when I say that, I bring some evidences as well, starting from the data collection, assessment through the assessment, using such evidence to the planning, using this planning to develop the capacities, and then using these capacities to safeguard the communities, not to mention the elderly population. So when we talk about a specific group of population, we need to think about this whole circle, that how this can be, the issues and challenges are embedded everywhere. So from the data collection to inclusive planning, capacity development, early warning, then social protection, monitoring, evaluation, moving into response. And all this together would only ensure a very effective and timely response. So we can ask this question, are we doing it by ourselves? Any of us around the table. If you see on this side, you will see that a lot of people are engaged in it. It's not only job alone for a particular group. It is everybody's job. That's the reason it's very important to identify the partners at different levels, different phases, for the preparedness, for the response, for the recovery, for data collection, and then distribute distribute the task and work together. This is the only way to approach this issue, because there is no other alternative but to integrate all the vulnerabilities into one approach for disaster risk management. Why I'm saying that? Because at the end of the day, at the country level, at the community level, it's just one system we are talking about. Unfortunately, we don't have luxury of developing multiple systems, but an integrated system, because of the finance, because of the resource, and because of the whole system being very functional. So I would like to highlight only a few things here. One, when we talk about the vulnerabilities, it always point out the challenges, but we need to think that these are not only challenges, these are also the opportunities, because aging is not just just like losing youth. Aging is also a new stage of opportunity and strength. We need to understand that. We need to design our system accordingly. So as I showed, like from the data collection to the response and recovery system, integrating these components, integrating these unique measures to address the unique challenges around the vulnerable population like elderly people needs to be embedded in all disaster preparedness efforts and humanitarian plans, as well the policies. The second thing is, when we have the policy plans and community, policy plans and also communication strategy and then capacity development, what we often do, we prioritize. And due to the very minimum and scarce resources available, this prioritization often missed out one thing, this the most vulnerable group. And I have seen it in many instances. So that's a reason we should be very, very particular to ensure that all these approaches have sustainable financing to address the challenges faced by elderly population, because they are the power in our community to tell us what went right, what went wrong, to build the future. And then also we should not only look at the elderly population as the vulnerable group. We also need to find out the strengths and opportunity, that how we can make this elderly population as the agent of risk reduction. As I said in the beginning, that elderly population, they are the connection between the past and future. And this is where, what I grew up in a family where my grandparents used to tell a lot of stories. And I can tell you that those lot of stories always included something to learn. So I think that this is also another initiative we need to utilize, we need to intervene, we need to research more, we need to learn more how we can use this interface between the past and future to build a very sustainable and a stronger generation ahead, and the world. Again, you can see that UNDRR already designated one of the International Day for Disaster Risk Reduction for the older people, that they must be included in all disaster planning. And then this year, the same day, International Day for Disaster Risk Reduction, 13th October, will focus Everyday Counts, Act for Resilience Today. And if we need to act for resilience today, we don't have any choice but to focus here, because just to make sure disaster do not discriminate, neither should preparedness. Let's ensure our older populations stay safe, resilient, and ready for any catastrophe, which will make all of us safer. Thank you, and over to you.
Muchas gracias, doctora Huda. Muchas gracias por su presentación.
Thank you very much, Doctor, for your presentation. A message that I would like us all to be left with, which is confirmed by the data, regardless of the geography, of age, of the socioeconomic development, of the type of emergency that we're talking about. The most affected populational group are older persons. And so that should be a focus, that should be a priority. So I would like to now welcome Ambassador Luis Gallegos Chiriboga, who's going to present to us the Global Initiative for Aging. Ambassador, thank you very much. That's very kind of you. I would like to thank you very much for your introduction. And I would also like to greet my fellow panelists. I am going to present in English.
Dr. Vega for the presentation, and I'm very honored to join the panelists. I joined the panelists as the president of the Global Initiative on Aging Foundation, which we created after the pandemic, thinking about the issues of older adults and aging. I also had the distinct pleasure of joining this event with Marcy Roth, the CEO of WID. I have the distinction of being also the president of the board of the World Institute on Disability. I joined the Decade of Healthy Aging because I am the president of the board of UNDRR, the United Nations Agency for Training and Research. Having said that, let me tell you that my antecedent will be to talk about rights. My formation as a diplomat and as a human rights expert and as a lawyer concentrate on the issue of rights. I had the privilege and the honor of chairing the negotiations of the CRPD, the Convention for Persons with Disabilities from 2002 to 2005. And I have had the honor of working with the disability community during the last 25 years or more in the concept of making a convention, which I find is the most successful human rights convention in present history. It encompasses more than 191 parties and member states, which represent the population of 1.3 billion people who have a disability. One is born with a disability, or one acquires a disability by accident, by sickness, by war, as we see every day in our screens, unfortunately. But we are sure that the aging, as I am a person who is aging, I am part of this cohort. 65% of the persons who are aging will have some type of event or disability during their lifetime. We are talking about a symbiosis between the issues of limitations, disability, and aging. The CRPD, which we negotiated in New York, in Article 11, states the situation of risk and humanitarian emergencies for persons with disability. It says the state parties shall take, in accordance with their obligations under international law, including international humanitarian law and international human rights law, all necessary measures to ensure the protection and safety of persons with disabilities in situations of risks, including armed conflict, humanitarian emergencies, and occurrences of natural disasters. I think the article was well formulated in the sense that we are talking about events of uncontrollable nature in most cases for a population that, talking about disability, represents 1.3 billion people. Dr. Huda just explained, and I think magnificently, the issues that we confront in all aspects of natural disasters and emergency risk reduction for persons with disabilities and aging. My principal concern is that we are 1 billion people who are aging. If I multiply that by an index of 2, which would be the direct impact group, which I find is a very relevant figure because one person who is aging will have at least one relative or one person or one community worker or health provider, etc., that will make at present a community of around 3 billion people. The tendency to aging, because of the lack of fertility, we are more aging people than children being born, is that in 25 years, by the year 2050, we will be nearing 2 billion people who are aging, which will make a cohort of 6 billion. This is a demographic shift of historic proportions. And I do not think that the governments of the world, the public entities of the world, are taking stock of implementing public policies to deal with this. I understand, having talked to more than 20 leaders of the world, that this is a very wicked problem. This is a very complex problem. It is a politically charged problem that affects borders, affects the social system, funding, health systems, and every other system in a society. As aging populations grow, you have problems of all types, of substitution of workers, active aging, prolonged longevity, and aspects that are of undoubtable importance for the conversation we are having today. The principles that we began when we negotiated the SDGs was leave no one behind. But the principle we talked about in human rights is nothing about us without us. I agree with Dr. Huda that we need to consult with people who are aging, or with community workers who are on the ground, on the levels of the context we are dealing with. I have in this context a very important situation. If we reach 2 billion people by 2050, we will have a different connotation of the ways we have to deal with it. I just been informed that I'm talking too fast in English, which is something that I never do. English is not my first language, and so I beg your excuses for the translators. I am very sorry. I will return to my script after this excuse, asking for your forgiveness on the speed of my talking, because I'd like to touch on the issue of the complicated international scenario we are living today, where inclusion is being put under question. The work we have done to have inclusive societies, to have dignified societies, to have persons with disabilities and aging integrated into the mainstream of political rights, into the mainstream of human rights, in the defense of what we need to have a dignified life and a dignified death as aging. We have, after 14 years of work in the United Nations, New York, the Working Group on Aging has finished its work, recommending a negotiation of a convention similar to the CRPD. We are very satisfied that in this month, there is a resolution that is being proposed in the Human Rights Council to create a working group to draft that convention. I think it is very important to stabilize, to have a rules-based issue that will keep us in the context of having a rights-based society. The only thing, governments are temporary. Situations and emergencies are obviously of great importance, but we must look at the future to dignify the lives of people who are aging and dignify the lives of all of us and our families. We leave this world in a situation in which we have undoubtedly advanced in technology to the point where we have enormous challenges, but enormous benefits with the artificial intelligence and others who will make life more livable for many. And we have to integrate technology into the livelihood of persons who are aging. Let me end by saying that I do believe that we are confronting a series of crisis situations like migration, like climate, like disaster risks all over the world, and that we are having a very dramatic situation in all countries with limited capabilities. Therefore, we must establish triangular South-South cooperation to help us. It is not only the lack of resources, it is also the capacity of dealing with this under a human dimension. Thank you very much.
Muchas gracias, embajador, por su excelente
Thank you so much,
presentación.
Ambassador, for
Yo
your
creo que
excellent presentation.
para mí queda un claro mensaje que la
For me, the
discriminación por
key
edad
message is
sigue
that
siendo un
age-based
factor
discrimination
estructural
continues to
importante
be
que
a
afecta a nuestra
structural
sociedad
factor
en
that
general
affects
y
our
en
society as a whole.
particular influye de manera
And in particular,
trascendental en el manejo de las situaciones de
it
emergencia
affects
y de
how
desastre.
emergency
Por
situations
ello
can
que el
be best
manejo de los
managed.
riesgos asociados a
Therefore,
ella,
risk management associated to these
debe tener un
situations
enfoque de equidad y
needs to consider
derecho
a
que refleje
rights-based
claramente
approach that will
estos
clearly reflect these aspects you mentioned.
Ahora doy la palabra a la doctora
I would now like to give
Mónica
the
Schoch,
floor to Dr. Monica
Spana, que nos va a hablar
Schoch-Spana,
de
who will
algunas
talk to us
consideraciones claves
about
en
some key
las situaciones
considerations
de disminución de riesgo,
when
la
reducing
disminución de riesgo en situaciones de
the
desastre para
risk
personas mayores.
in disaster
Así que,
situations for
Mónica.
older people. Go ahead, Monica.
Muchas gracias, señor Vega.
Thank you so much,
Let me
Dr.
share.
Vega.
It's my pleasure to talk with you today at a very granular level, as Dr. Huda had indicated. We need to understand there is the overarching challenge of older persons, but as Ambassador Gallegos has just indicated, there are demographic reasons why we really need to spotlight the needs of this population. I'm going to touch on the disaster experiences of older persons in the realms of warnings, evacuation response, disaster impacts and also recovery. And like Dr. Huda had pointed out, really address the positive aspects of being an older person in relation to disasters. So as Ambassador Gallegos indicated, the numbers tell us that we must pay attention here. In 5 years, 1 in every 6 people in the world will be aged 60 years or over. So let's talk about the challenges for older persons in the realm of warnings, evacuation, and response. There are a series of factors that influence the older person's ability to process and to act on risk and warning information. So there are normative age-related changes. There are impairments that are visual and also auditory. There are issues of the ability to pay attention, to remember, to text even. Some challenges in the realm of decision-making and comprehension. There are also, once the information is obtained, barriers to that will continue to create problems, and also those that inhibit acting on warnings. There's isolation, as Dr. Huda had pointed out. There may be diminished social networks. As people age, they may be losing friends and colleagues of a similar age. And there seems to be, according to the research, a lower rate of information seeking behavior by older persons. We also need to worry about barriers to evacuation. Now, this is culturally dependent, but there could be a sense of independence and not a desire to evacuate, but instead a desire to stay in a familiar place. Issues of mobility, higher rates of infirmity, inability to actually pay for a hotel in certain circumstances when people are evacuating. They may not have any caretaker to help them move, and they may be reliant on medical equipment that is difficult to move. And it isn't just enough to think about elderly in homes or older persons in homes. There are profound evacuation challenges for nursing home residents and assisted living residents. If there's an interruption of continuous care, people who are frail could rapidly decline in a medical situation. Also, depending on the facility itself, there could be uneven emergency preparedness and planning by facility leadership. We've talked about the issue of equipment. So in terms of evacuating people, there's the issue too of moving walkers, wheelchairs, specialized medical equipment. Is there enough space in the vehicles to accommodate that? There is the time delay with logistical challenges, so complicating and lengthening the duration of evacuation. There's the issue too of whether or not there are enough staff to help with individuals who have mobility challenges. And then, of course, in the rush to evacuate, there's the potential to leave behind medications, eyeglasses, dentures, and other supplies. Now, again, it's not enough to think about evacuation. There is also this protective action of sheltering in place. And even there, we're seeing challenges for older persons. The disaster conditions themselves can interrupt essential services like home health care, and for those who are dependent on the delivery of meals. The disaster too can take out critical infrastructure, leaving homebound older persons without electricity, running water, or access to news. Now, what are the impacts that older persons face? Well, there's a higher vulnerability in terms of risk of injury, mortality, and morbidity. And why is that so? Well, we have social and economic marginalization that can actually inhibit preparedness or mitigation steps by older persons. We've talked earlier about the visual and auditory challenges in terms of receiving and acting on warnings. We have the mobility challenges. And then also we have this reduced thermoregulatory capacity by both the elderly and the very young that could lead to increased susceptibility to temperature extremes. Other factors that place older persons at higher risk are the interruption of care and medication, the increase in stress levels that is associated with public sheltering, and the loss of meaningful places and possessions that can trigger additional trauma and distress. And sadly, the extra stress on the caregivers of older persons can contribute to instances of elder abuse. There are challenges in the realm of recovery as well. There can be age discrimination by government agencies, humanitarian organizations, and even communities who don't understand the special needs nor the importance of dignifying older persons. There may be overly bureaucratic agency procedures that discourage, intimidate, and frustrate older persons. Again, we've talked about the limited social networks that could otherwise help older persons navigate recovery aid systems. And again, dependent on the cultural context, there can be a generational emphasis on self-sufficiency or some perceived stigma against accepting help or welfare that deters an older person from seeking aid. There are whole categories of difficulties that older persons may experience. And I think it's important here, we've called out auditory or visual, mobility. There's also communication and cognition. I think what's important to call out here is that these challenges are not limited to older persons. All of us at some point in our life are going to suffer from these types of difficulties. So protections for older persons in each of these categories will contribute to protections for the entire population. I wouldn't want to leave you with the impression that older persons are inherently vulnerable and that there is no positive aspects of being a senior or older person in the disaster context. Dr. Huda had pointed this out as well. There are benefits of having lived a long life. There are the experiences of getting through hard times and recovering from loss before. So older persons can actually share their perspectives on getting through hard times. There's the psychological benefit for the older person of actually sharing their wisdom and experience with other survivors. And for those older persons who are retired from the workforce or aren't encumbered by childcare, they're available for volunteering. I wanted to give you a case study from the catastrophic Hurricane Katrina and the flooding in the city of New Orleans in Louisiana in the United States, because it tells the story both of the vulnerability of older persons, but also their profound resilience. Now, sadly, in the context of Katrina, it was the oldest adults who died as a result of the hurricane and lack of support in the largest numbers in the context of Hurricane Katrina. But over time, the elderly who survived were able to approach the disaster with a long view and comparing the impacts to other traumatic events in their lives. So they were able to share the experiences that one can get through adverse moments in one's life. Also, too, the sense that there are primary values that are important, like family and simple pleasures. Their resilience was in contrast to the increasing stress and frustration that was experienced among middle-aged survivors. Now, these are people who were burdened by the need to rebuild, to find employment, to work, and also care for children and parents simultaneously. So while the elderly experience the most morbidity and mortality at the beginning of at the hurricane in the immediate aftermath, you saw increasing morbidity among middle-aged survivors, the feeling that they had lost too much and they were never going to never be able to dig themselves out of a hole, and a sense of premature aging. So just to leave you with a few takeaways, every country in the world is experiencing growth in both size and proportion of older persons in the populations. They face challenges in processing and acting on risk and warning information. They're at higher risk of injury, morbidity, and mortality, but age and senior status are sources of resilience. These individuals have perspective on hard times. They can share wisdom and experience, and they are have the time to volunteer. Thank you very much.
Thank you very much, Monica. We almost don't have time for questions, but there is a lot of questions in the chat that many of them are already answering by the presentation. But we will, if we got the time to the first one for just answer a question, I will ask the panelists if they could help me to answer in very brief way. What are the main challenges in integrating an equity-based approach in disaster management in urban settings? Is the most common one in the presentation, but I would like to specifically try to get from you one specific measure that you consider that could be implemented to improve the inclusion of other persons in emergency and disaster planning. If you must choose one, what would be? I don't know, who is the first in the panel that want to answer around?
I think we need public policies that respond to these needs. We need an illustrated leadership that understands the problem and is willing to have a state-based responsibility on the issues of disaster risk, with disaster health, disaster and disaster risk, with international cooperation, because these issues are not only national or community-based, they are also international affairs.
Dr. Huda?
I thank you very much. I think that this is the question we all need to answer. It's not like, who or who else. I completely agree with Ambassador Louis. It's very important, yes, policy support, but at the same time, I also think that accountability is key here as well. So, because policy, we have a lot of policies. I referred quite a few UN legislations. From the United Nations side, there are a lot from non-UN side. Many countries, they have it in policy. We need to find out, how much of that policy are being implemented. Because I was just now answering a question. Somebody put on the question and answer box, just addressing me, saying that the stories I referred that, we could learn so much from our elderly population. How much of those are documented? I think this is a task given now. We all should be taking it up. This one thing, it's take away from this session that I'm not very aware that there are too much of it. For my personal experience, working across the different countries around in the world, I have learned so much. I have heard so many stories, and few of them are, of course, documented. But I think that this is one thing we should seriously think about. how we can document those experiences, because our future world is literally standing on those experiences. The stories would tell us what went wrong, what went right. So we don't want to reinvent the wheel. We can just discard what went wrong, and we can just go ahead with what went right. And what we can, like, we talk about ecosystem these days. We talk about climate issues. We talk about nature-based solution. A lot of solutions are coming from the experience. Like, in olden days, people were predicting the earthquake when they saw the specific movement of the ants. That's what I learned from a community where I was actually responding to earthquake in Banda Aceh. And I learned from this community. They said, from the movement of the ant, we know that. If this is like, one of the early warning, and this is so much within the community, when we think about the AI-driven, specific technology-driven early warning, we need to bring those things closer, how we can build on this existing knowledge, which is so natural. This would be a real ecosystem. This would be real nature-based solution. Thank you, and back to you, Dr. Vega.
No, thanks, Dr. Huda. And Dr. Schoch, please.
Yes, as Dr. Huda points out, I think it's those first-person accounts of the experience of disasters and getting through it, and the inclusivity of senior citizens and the agencies that represent their interest. We really do need to put into play our policies of inclusivity. We have to include enough resources to bring older persons to the table, starting at the very local level, and according their expertise in preparing, responding to, and recovering from these events.
Okay, it's a great answers for very important and difficult question to cover. So, Alex, I think that we are on time, and we are covered on time. There is a lot of questions in the chat. If the panelists can answer some of them, if they got the time to do that, and then we are also a lot of resources that the organizers are covering and put it in the system. So I think that that will be an initial conversation, just an initial conversation that we need to continue growing in the future. So Alex, to you. Thank you.
Thank you, Enrique, and thank you to all the panelists. It was a great presentation, a lot of information and key aspects that we must highlight in our practice. It is important to mention that it's kind of the kick-off for us from PAHO in the work that we are considering and also moving towards the importance of including all persons in disaster risk management. So now I'd like to give the floor to my esteemed colleague, Marcy Road, Executive Director of the World Institute on Disability, to moderate the part 2 of this session that is focused on critical infrastructure in cities, resilient hospitals to help emergencies and disasters. Over to you, Mercy. Glad that you are here, and thank you to all the panelists in this part 2 session.
Thank you so much. I am, okay. Bear with me 1 minute. I wasn't able to share screen until now. And my presentation seems to have disappeared. Bear with me just 1 moment. You know what? I'm going to skip my slides. I don't know where they went. So I will stop sharing, and I want very much to welcome our next panel in this very important series of discussions: critical infrastructure in cities, resilient hospitals to health emergencies and disasters. I'm Marcy Roth, and I'm the Executive Director and CEO of the World Institute on Disability. I'm from the United States, and I'm delighted to be your moderator. We will hear from 4 distinguished experts on various aspects of this topic, and I will briefly set the stage with a few of my own opening remarks. My organization, the World Institute on Disability, was founded by disability rights leaders 42 years ago, and it has been continually led by people with disabilities. My own experience in this space stretches back to 2001, when, as a leader in disability policy, I was called into the White House to advise on meeting the immediate and ongoing needs of people with disabilities affected by the terrorist attacks in 2001. I've been working globally in all aspects of the rights and leadership of people with disabilities before, during, and after disasters since 2001. And I want to touch on a few of what I think are critical elements of the aspects of this topic. And the first one that I would like to address is the fact that we have 1.3 billion people with disabilities globally, and the Sendai framework has very specifically focused on not only our needs, but as well on our contributions, our rights, our ability to make notable contributions and to serve in leadership roles. This is especially important as we think about the design of critical infrastructure in cities, and our resilience in health emergencies. I want to as well touch on some of the key principles for disability-inclusive disaster risk reduction, including fundamental integration, whole community approach, nothing about us without us, and I will add to that, nothing without us. It's not just things about people with disabilities, it's our value as leaders. Accessible ICT innovation, sustainability and universal accessibility, and resilience. In 2023, there was a global survey on disability and disasters that was led by UNDRR, and the results showed limited progress in disability inclusion over the past 10 years, with no significant differences across the regions. This is unfortunate, and I think we are all quite confident that we can do better. So one of the key areas that I think we have an opportunity to focus on is the Early Warnings for All initiative, which is a groundbreaking effort to ensure that everyone on Earth is protected from hazardous weather, water, or climate events through life-saving early warning systems by the end of 2027. The Secretary General has given us a very ambitious timeline. And as we talk about today's topic, I think it is particularly important that we think about early warnings in the context of the needs of the whole community and the infrastructure that is expected to serve resilient, to be resilient in times of disasters. So the Early Warnings for All initiative needs to be not only inclusive of actionable and accessible information, but it needs to be centered around actionable and accessible communication. And I think it's especially important that we keep in mind that this is not just about accessibility for people with disabilities or older people. This is, in fact, about everyone having information so that they can take personal protective measures, so that they can assist their family, their neighborhood, and their community. So I will now be introducing our first topic and our first speaker. Our first topic is Resilient Hospital for Health Emergencies and Disasters Framework and Universal Health Coverage. And I am very pleased to introduce Hamid Ravaghi, PhD, who is the Regional Advisor for Hospital Care and Management in the Department of UHC Health Systems from WHO EMRO. Go ahead, Doctor.
Thank you very much. Good morning, good afternoon, good evening, colleagues. It's my pleasure to be part of this esteemed panel and be part of this discussion today. I'm happy that colleagues emphasized a lot regarding the older people and people with disability in the time of emergencies and different aspects of this. I would like to emphasize the recent work that we have done with the PAHO, between EMRO and PAHO, to develop the resilient hospital framework and how we can operationalize it, and also include as using the No One Left Behind to see how we can incorporate the older people and people with disabilities. So the role of hospitals after COVID was more prominent, as our colleague from PAHO mentioned, that COVID showed us that we are not well prepared, and we are not, enough prepared to respond to different emergencies. And also cities are not, exceptional, that we are facing the growing health emergencies, pandemics, urbanization issues, climate change, and hospital are a critical part of this health system response, but they are not in silo. They are part of the health system. They are part of the community, and the role of hospital ensure that health system can withstand, adapt, and recover from crisis. And so, but after COVID-19, in our region that we are covering 22 countries, they requested us how we can make the hospital more resilient. So we started doing a comprehensive study, including the scoping review and the qualitative study, interviewing the people, having the expert consultation at the global level. And we understood that we need to strengthen the hospital resilience, health system resilience, but unfortunately there was limited evidence in the literature, specifically in low and middle income countries, and from the prevention, preparedness, response, and recovery as components of the resilience. Most of the literature is focused on preparedness, and most of the literature are conceptual, and there is not much on how. Most of the literature was talking about what does it mean, and specifically focusing on natural disasters. Our scoping review showed that surprisingly 75% of the article included in our review was after 2017. And on health system resilience, 63% of the articles was from between the 16 to 19 and 25% in 2019, which means that it is a new topic and we need to work more on this. Even we saw the divergence in conceptualization, and this divergence even make it more difficult how we operationalize, how we evaluate the hospital resilience, specifically in the context of low and middle income countries. So the principle is definitely we need to strengthen the health system in routine time and link it to the disaster risk management cycle and disaster resilience. And as part of as our DG mentioned, that the UHC as part of the the result of health system strengthening and health security are two sides of the coin. So we need to link them together in order to have a resilient health system. But what is the role of hospitals? How we can provide applicable and practical for hospital manager? I was a hospital manager for years and years. Many of those theories or conceptual models comes to the hospital managers, but they need to know how they respond, how they work, and in terms of the very practical way. For this reason, in order to conceptualize the hospital resilience, we used 4 questions. To me, I think it's very useful to see how we look at the hospital resilience. We say hospital resilience for what? Hospital resilience to what? Hospital resilience through what? And of what? As colleagues mentioned, hospital resilience for what? In order to maintain the essential services during the emergencies. So we need to be prepared and during the emergency, provide essential services, life-saving, continue the critical, and leaving no one behind. When we say leaving no one behind, this is a very important, but how the hospital can be part of this leaving no one behind. Definitely, as I mentioned, they should be as part of the health system, as part of the community resilience, health system resilience. Hospitals should work within this, more, higher level framework. So I saw one of the colleagues in the Q&A, they mentioned leaving no one behind might be a slogan, or, it's in the reality is not easy. Are we talking about only our city, our village, or we are talking about the global no one behind? In all, COVID-19 showed us that we need to have a solidarity. And we are talking about a very local level to global level. So if we maintain the essential services, the outcome would be impact and impact would be on UHC, universal health coverage, on health security and health equity. And the older people and the people with disability are not exceptional. However, unfortunately, in our region, at least based on our work, there are not much plans and practice bringing the vulnerable and older people within the preparedness plan. And as you know, in our region, 11 countries out of 22 countries are, experiencing different level of graded emergencies. So our region is part of it. We have so many displaced people, so many refugee migrants, and among them, so many, elder people and also disabled. So therefore, we need to include this as part of the incorporate as part of the plan. It should be as an accessible infrastructure, disability inclusive emergency plans, and also, as our colleague mentioned, regarding early warning system as well, it should be included. Resilience to what? We discuss about the all-hazard approach. We have a different level, different hazard, different risk. The climate change is natural and man-made. It's the biological. So how a hospital manager can be responsive to all hazards, because we say it is all-hazard approach. And the response is we need to be prepared to all hazard. We need to respond. But the main entry point is risk identification, risk prioritization. So we need to do the risk assessment for our hospitals and for our, the community. And based on this prioritization, we prioritize those risks. And many of the activities, many of the intervention strategies we choose are mostly similar among different hazards. 20-30% are specific to the specific hazard. For example, we need a EOC, we need a communication strategy, we need a contingency plan. We need different things that is similar to the al-hazard. Therefore, to what our approach is context-specific, all-hazard approach, risk identification, risk assessment, risk prioritization. Through what? Hospital resilience, we need to respond, to consider all components of the resilience, from the prevention, preparedness, response, and recovery. But as I mentioned, most of the literature is focused on the preparedness. much less on prevention and recovery. And as you see in this chart, once we asked our countries in a survey that we have done, that how much change regarding resilience before COVID and after you felt in your hospital, you can see the orange and the green one. Now the hospital managers, the health system are realizing that we need to be more resilient, but it should be through whole disaster risk management cycle. And resilience of what? We need to empower, reduce vulnerability and empower our capacities. And we package it under the 6S. We need to have a better infrastructure, agile infrastructure, adaptable infrastructure. We package under a space. And also, we should have a competent, trained, ready staff and well supported. Also, we need to have a staff that is a logistic and finance. We need to have a system. We need to have a strategies and services. Once we put, sorry. Once we put all together, we developed a framework in order to operationalize hospital resilience. As you see here, in the heart of this framework is 6S. We need to improve and strengthen the space, staff systems, strategies, and space in order to have, the stronger. But hospital doesn't work in silo. Hospital works as part of health system, as part of community to respond to all hazards, and it should be risk informed. And as you see, it is from the prevention to recovery in order to give the capacity to absorb, adapt, transform, and we learn from the previous one and also be prepared for the next one. In order to operationalize this framework, we intersect the of what and through what, of what of those components, 6S, and through what during the disaster risk management cycle, and we develop the matrix. This matrix gives the hospital directors, hospital manager, hospital team very clear what they need to do in each phase of the emergency response and emergency preparedness and response in terms of hard resilience and soft resilience. And we developed this, and based on this, we provided the operational guide, very detailed, very practical, letting the hospitals to do some baseline assessment to know where they are with the different tools, different activities. So we try to be part of the practice rather than providing just the guideline that doesn't show how. We provided which activities needed, what tools are needed, and we provided them. So we piloted this, and it names as an interregional guidance on strengthening resilience. We piloted this in 7 countries in our region, in different contexts. We piloted in Yemen and Syria and Pakistan. We piloted in Oman and Iran, and it worked very well.
Please wrap up.
It was, very well understood, very well taken, and implemented. Now we are trying to cascade to all countries. We piloted in more than 20 hospitals. We learned a lot, and also we know which kind of adjustment we need to do this. My take-home message: resilient and inclusive cities need a strong and accessible and prepared health system, and hospitals at heart of this effort as part of the broader health system and community. Leaving no one behind should be a must, but it should be practical. We need to see how hospitals should work with primary health care within the community, using referral networks, with a strengthened community, empowered community, and also, as Dr. Qudsia showed to that slide very well is the cross-sector collaboration in order to strengthen the policies in this regard, leveraging on the new technologies and AI and facilitated decision making. And we shouldn't forget that we need a resilient hospital, and also we as a health system and also hospital, we should reduce our environmental impact. And as our colleague in the introduction mentioned, now we have a safe and green, which is a smart hospital. So the position of the people with disability and elderly, I think they should be much more prominent, incorporated within our plans, which is lacking, or even if it is very minimal, and is not even in our exercises, in our drills, in our training. There is not much attention to this. We need to learn more. We need to have the good case studies and the best practices in order to incorporate in a practical way. I thank you for your attention, and I do appreciate the work that and also leadership Dr. Alex Camacho provided in our collaborative work. Thank you very much.
Thank you very much, Dr. Ravaghi. That was
Mercy. Just a quick message. We have a lot of questions in the Q&A and also in a Slido. I kindly ask our esteemed panelists, please, to respond directly to the Q&A. We are a little bit back in the time, so please help us responding directly in the Q&A. We also are sharing very important links regarding the documents that Hamid have mentioned and other colleagues. Thank you, Mercy, and please go ahead. Sorry for the interruption.
No, that's okay. Thank you, Alex. And again, so much important information and a really positive way forward. Let's now hear from two speakers on resilient health infrastructure in urban context. Our speakers will be Ms. Sarga, GS, analyst, Urban Resilience Coalition for Disaster Resilient Infrastructure, and Ratnesh Kumar. Dr. Kumar is lead specialist, knowledge management, also from the Coalition for Disaster Resilient Infrastructure. Go ahead, please.
Hello all. Good morning, good evening, and warm greetings from CDRI Secretariat, New Delhi. It's an honor to be part of today's discussion and also listening to esteemed panelists who emphasized the relevance of resilient health infrastructure and also the vulnerability, especially for the elderly group. In our today's intervention, me and Mr. Ratnesh Kumar would like to share more about what CDRI is doing as an organization in this domain, and also provide a quick overview of our urban and health initiative. And the key target is actually to advocate for our ongoing initiatives. And basically, if you see any potential synergies where we can partner with, collaborate, share resources, or learn from each other, have that opportunity to connect. Now, as a starting point, I would like to provide a brief overview of our organization. CDRI is a global partnership of various national governments, multilateral development banks, and UN agencies with an aim to improve resilience of existing and upcoming infrastructure. So CDRI was launched at the prestigious UN Climate Action Summit 2019 by the Honorable Prime Minister of India. And today we are a partnership of 43 countries and 7 organizations. Next slide, please. So various strategic initiatives and by critical technical assistance programs. Our work span across 29 countries. Now our sectors of intervention include power sector resilience, transport, health, governance. We also have geographically specific initiatives including small island development states. and the mountain program and the urban initiative. Here, the vulnerability in terms of users have been emphasized much by the previous speakers. Now, as we discuss the urban context and then specifically to the health initiative by CDRI, maybe I could highlight some of the key hazard perspective on it. Now, speaking about our urban initiative, urban is a very strategic initiative by CDRI, and via this initiative, we look forward to enhancing resilience by implementing data-driven decision-making to manage urban shocks and stress. So this was actually an outcome of consultations with global experts, about 60 of them, which finally culminated in the launch of our strategy at COP28. I would take a pause here. I can see few comments on making the slideshow full screen. So may I please request my colleague, Dr. Ratnesh, to
Yes,
change the
please.
format?
Ratnesh or Sarja, at the display settings in the upper side of the screen, you have the display settings, and then you can click and select the presenting mode.
This is okay? Like, I see it's a...
You may have a presentation mode, mode where you can select and switch in the displays. At the display settings side, you can select the presenter mode. You can hide the presenter view, there.
Okay. Okay.
And then now, okay, turn on the full presentation.
And the notes. What did you say? Sorry.
It's okay. You can continue. It's okay.
Yes. So moving forward, I was speaking about our urban program was launched at COP28, and what we have emphasized is our program prioritized the low and middle income countries and small island development states who are mostly impacted by the emerging climate risk, the climate variability, and other risks. So even though the global challenges of extreme heat and flooding impact everyone, considering the existing infrastructure deficit, resource gap, and limited technical resources, it was found that these are the regions that require most of our targeted intervention. Now, in the initial phase of our urban program, our focus is on the following hazards: extreme heat, flooding, water scarcity, and security. Via our initiative, we look forward to ensuring city infrastructure, environment, services, and systems are resilient against climate extremes. This we are planning to achieve by improved member country engagements, increasing access to infrastructure finance through MDBs, access to data, tools, and knowledge by urban local bodies. Next slide, please.
So do I have the control? Like,
That maybe you could stop sharing and I can try screen sharing to address the issue.
okay. Sorry. Yeah, stop.
So screen visible?
Now you have a full screen mode. Go ahead, please.
Okay, thank you. So yes, this is an overall roadmap of how we are implementing our urban program. For the interest of time, I would not like to go into details. But basically, for improved awareness and capacities, we are developing training modules for each of these critical infrastructure. On water, we are developing one, and health will be a focus we will be considering in the coming time. Also, to ensure informed infrastructure operations and maintenance, we have a community of practitioners where we convene experts across the globe, basically to create a standard operation procedure document which could be informing the infrastructure managers or operators. And additionally, a key intervention as part of our urban program was the call for proposals. So this call was launched last year, and this January, the deadline, after the deadline, we received significant interest to stress upon the key sectors which we focused as part of our urban call. The hazards were extreme heat and flooding, water scarcity, security. Sectors in focus, hospital was one among the 5 sectors we welcomed proposals from. And the themes which we addressed were project development support for risk-informed design and development, data, resilient recovery, and also risk finance, including nature-based infrastructure solutions. We received an overwhelming interest from various applicants, and especially from 6 regions. About 150 plus cities had applied for the call. The point of interest is the emphasis on health sector was much relevant from these proposals, and most of them discussed health as emphasized by the panelists earlier. They were looking at a systems approach where hospitals were not seen in silos, but we do understand where a power outage would directly impact the ventilator systems for a hospitals, or where a water supply issue can also tamper the functioning of a healthcare system. So considering a systems approach is very important for an resilient city infrastructure systems in general. Now, among these different hazards, heat health interface is something we should really speak much about now. It's also the global heat season, where last year marked the highest, the warmest year on record, and this year, Jan also was the 19th consecutive month of record high temperature, also surpassing the 1.75 degree border of pre-industrial average. Now, as per the stats, it says that every 1 degree increase in temperature after a border of about 29 degrees Celsius might result to a 4% increase in hospital admissions. So when there is a 4% increase in admissions, especially for low and middle income countries or vulnerable regions, it's actually adding on to the existing resource gap, further stressing the existing infrastructure systems. Now, the added lens from a vulnerability perspective to it is the vulnerable group, especially elderly, women, children, differently abled, or the marginalized group, are significantly impacted by this rising heat. Now, it might have its nuances, but if we generally speak, we see that in comparison to people who commute for work, the vulnerable group, especially elderly or women, commute often during the peak heat hours. That is the non-office hours.
I think we need to be conscious of time. Sorry.
Thank you, Ratnesh. Where they are traveling more in these peak hours. So it's important to consider the needs of the day. And as we are short of time, my 3 key messages while we consider for resilient health systems in cities is project preparedness support, including risk and hazard assessment. Second, disaggregated data on health infrastructure systems and user needs. And third is the systems approach, where we are seeing the interdependencies of cities and its various sectors, and not looking at health in silo. That would be a summary statement from my end from an urban perspective. Now I pass the mic on to my fellow colleague, Dr. Ratnesh, who can take you through the details from a health perspective in general. Thank you. Over to you, Mr. Ratnesh.
Okay, thank you. So can you show next slide? So if we, thank you, Sarga, and if we reconnect back to Dr. Hamid, that the need for why do we need resilient hospitals. So I try to map, some of the impacts of disaster on health system. So, if we see it very broader level, then there are 3 levels of impact. First is on public health, where, we have casualties, injuries. Then we have mixed vaccination, delayed treatments, and chances of outbreak and all. So these are impacts on public health. The second level of impact is on hospital operations. So when you have disasters, and then so there is a need for surge capacity within the hospital. So the example you see in the image is a data from a hospital where the peak load rose to 75% of the routine load. So how do we build our hospital, which are not just safe from the various hazards, but capable to adapt to various shocks? And on the third level of impact is health infrastructure, where there are damages to assets, hospital assets. Then we have to create temporary facilities and camps, and field hospitals and all. And then third, the other impact is that disruption of critical infrastructure services such as transport, power, water, and telecom. Now, how these different kind of impact affect the elderly and persons with disability. So if you go to next slide. Next slide, sir. Okay. It's okay. No, back. Sorry. So if we see these 3 different levels of impact on older people or persons with disability, then the elderly and disabled people are more vulnerable to injuries. They have slow recovery, and they have reduced quality care because there will be more patients. There might be more patients in the family and community. So this actually impacts their both health and recovery process. Now, due to disruption in the hospital operations, we see so during the evacuation of the hospital, as we saw from the previous speakers, that during evacuation, it's very difficult to evacuate disabled or older people. There are disruption in routine and ongoing treatments. And then there are loss of medical records, fewer dedicated healthcare workers, and space to take care of the elderly people. And also we know that older people and disabled people have limited livelihood scenarios, and they have less income. So it also affects their ability to afford the medical care. On the third level, when we see that the roads are impacted or the transport systems are impacted, that is the impact on critical infrastructure services. We see that there are some makeshift bridges through which the elderly people have to pass. So in the image you can see it's a more than 100-meter long bamboo bridge which swings. So how elderly or disabled people can cross this bridge after disaster? So these scenarios highlight that we need to focus on building resilient hospitals, but we need to integrate the systems approach to it. And I'll just present a short case study in 2 minutes. Next slide. Next slide. So this is a case study from a state in Sikkim, India. It's located in Himalayas. So we have been CDRI in partnership with WHO. We have been working with Sikkim government to help them build resilience to climate change and disaster events. So our approach has been very consultative process, and we have taken multi-hazard approach, as Dr. Hamid had highlighted. There are systems of system approach. We are not just focusing on the hospitals, but all the critical infrastructure services that support the operations of the hospital. And we have been inclusive and inclusive in terms of older and disabled people. Now, the interventions we did was, as again, Dr. Hamid had highlighted, that risk and resilience assessment of the hospitals, capacity building, one of the most important factors. So we did CDRI and WHO did capacity building of more than 500 staff covering all the hospitals in the state. And then we also provided technical support to state in developing their customized disaster risk management plan, and also the resilience plan for their hospital. So these documents are in final stages of discussion with the government. And together we are bringing all the lessons in developing a policy roadmap which can help the government build a long-term resilience, long-term resilience in the state. So overall, the message is that, yes. Thank you. So this is the last slide.
Thank you very much. I didn't mean to make you stop right that moment, but thank you very much to both of you. That was very informative, great examples, and much for us to continue to consider. Our final speaker for this panel is going to speak on disability inclusion. Okay. Is going to speak on disability inclusion in hospital emergency and disaster risk management. Dr. Felipe Cruz Vega, head of the coordination of special projects in health of the medical benefits direction of the Mexican Social Security Institute. Please go ahead, Dr. Vega.
Muy buenos días para los que estamos acá en América del Norte.
Good day, good morning to all of you, all of us who are here in Americas region, or the North America. I'm going to give my talk in Spanish. And in the next 10 minutes, we're going to be looking at INGRID H, which is a Spanish acronym, which is something which is being implemented in hospitals. We're going to look at some of its results. Dr. Alex Camacho is the one who has been responsible for this initiative for many years, and he has a vast experience in this area. Since 2003, the Mexican Institute of Social Security, through inclusive measures, has been trying to make safer and healthier institutes that are better able to respond to emergencies, that are environmentally friendly, and that respect the rights of all groups who are in a situation of vulnerability. Therefore, our institution, in collaboration with the WHO, has driven the incorporation of a safe hospital program. So this has to do with evaluating hospitals and then having a multi-hazard approach. Because it's not that all hurricanes or all seismic activity are multi-hazard. The expansion of capacities requires us to apply protocols, special protocols, when the emergency services are saturated, and we have a huge amount of victims. So we need to have a sustainable system that respects the health of our planet by reducing our carbon footprint and our management of electricity, water, among other things. And we also have to be ready to help the groups who are most vulnerable and who have health security.
The Mexican Social Security Institute is very much committed to the rights of people in vulnerability. That's why we introduced this proposal here that has a human rights approach and a gender perspective. And this policy can be best represented by this pentagon here, which focuses on the 5 basic elements: adaptability, acceptability, quality, availability, and accessibility, all in order to materialize the right to health, especially in the context of health emergencies and disasters. So this then is part of the initiative developed by PAHO and WHO to include risk management. And this strategy is known as INGRID-H. That's the acronym in Spanish. INGRID-H is an evaluation action methodology that is intended to improve the level of inclusion of persons with disabilities that are in health risk, disaster risk management, particularly in hospital preparedness and response to emergencies and disasters. The methodology behind INGRID-H focuses on 5 aspects and covers 13 specific actions. First, visibility, so that we can cater to the specific needs of persons with disabilities during the response to emergencies and disasters. And for that, we need to know who they are, where they are, and what do they need. Participation. This means making people with disabilities be duly represented in the hospital emergency committee and be consulted about any activity that pertains to disaster risk management. Universal accessibility. This is about understanding and visualizing that the evacuation routes offer autonomous ways for persons with disabilities to leave the hospital. Capacities focuses on assessing whether the hospital structures and other physical means comply with accessibility requirements from a universal perspective. Then there's hospital plan, which helps us identify whether the needs of persons with disabilities are actually included in the emergency response and disaster plan. And this needs to be updated, socialized, and regularly reviewed by means of drills. This figure here illustrates INGRID-H methodological cycle. As you can see here, these are the activities that need to be conducted in a short amount of time. It has 3 phases: evaluation, implementation, and check. These principles are then integrated in a broader methodology, which is based on continuing training, and this is offered to all healthcare professionals from primary and second level healthcare services. When we implemented INGRID-H in my institution, we did this because first we wanted to homologate or validate the concepts and standardize evaluations and implementation. We wanted to offer on-site training to all healthcare workers involved. And so we trained 230 healthcare workers on INGRID-H. This was an on-site workshop labeled Towards a Culture of Inclusion. We also held online sessions, and we trained 404 managers from 276 hospitals all over the country. And we also offered online and on-site technical assistance to implement this action plan. This technical assistance was offered online and on-site and available to all hospitals in the country. How did we go about completing the first cycle? During the first stage of self-evaluation, 220 hospitals were covered. 24 of them were labeled as potentially excluding, 8% as inclusive, and 68% were labeled as excluding. The second stage involved implementation and verification visits. These covered 32 hospitals. And we wanted to check the status and the level of the trainers who had been trained before. So we focused on this action plan, we visited the hospitals, and we visited the areas where persons with disabilities work. We also held a number of interviews in order to find out what the needs are in the context of emergencies. And they also participated in a session focused known as For a Culture of Inclusion. 180 days later, 245 hospitals reported their new self-assessment results, as you can see on this chart here, which shows significant progress. 41% of these hospitals were now self-assessed as excluding, 43% as probably inclusive, and 23% as inclusive. Next, you can see here an example of how inclusion levels improved for risk and disaster management after implementing this tool. This hospital here obtained a score of 53.88%, which means it was possibly inclusive. After the intervention and implementing the action plan at this hospital, the second self-assessment took place 180 days later, and now the score was 79.78%. And so this hospital was now labeled as inclusive. Talking about actions that were introduced to improve accessibility and inclusions include staff training, both on-site and remotely. This involves training governance workers, governance entities, and also personnel and all shifts. This also involves placing signs and signage, pictograms with Braille language, for example. Another action involves training healthcare personnel and brigade in sign language courses. Also conductive, inclusive simulations and drills. And in here, we've included the variable of disability, as you can see on these images. We've also held consultations with persons with disabilities, asking them about risk management and how to best update management plans. Now, talking about which aspects are necessary to ensure accessibility. Well, it's important to ensure accessible parking, visual alarms in addition to audible alarms, making sure that restrooms are accessible, family-friendly restrooms in this sense, which can offer both accessibility and dignity. And also it's important to use clear, visible signage. Conclusions from this. We still have a long way to go, but the important thing is that we've started on this journey, and from now on, we can improve and strengthen our capacities. For that, we need to train healthcare providers to understand and respect the unique needs of people with disabilities. Secondly, we need universal design and accessible environments to access healthcare. This includes addressing ramps, elevators, and accessible medical devices. Number 3, disaster information needs to be made available in accessible formats such as Braille, sign language, and easy-to-read materials. It's also important to collect data and disaggregate data for decision-making so as to guarantee the health rights of persons with disabilities. By addressing these barriers and promoting inclusive practices, we can create a more equitable and resilient health system that will support everyone with no distinction, especially during emergencies and disasters. Ingrid H. will not only help fulfill the rights of persons with disabilities, it will also support countries' efforts to create safer, inclusive, and resilient health systems. We need to move on from diction to action. Thank you very much.
Thank you.
Thank you very much, Doctor. This was brilliant. Ingrid H. is a model that I have watched thanks to Alex over many years, and this methodology is a model for us all to learn from, implement, and support. Thank you to all of our speakers. Clearly, we have solutions to improve outcomes And the World Institute on Disability welcomes the opportunity to work with all of you moving forward. Alex, back to you.
Thank you, Mercy. Thank you to all our distinguished panelists, especially in the part 2. Thank you, Felipe. Thank you, Hamid, Radnesh, and his team. Thank you to panelists in the part 1, Dr. Gallegos. Felipe Cruz is a champion in hospital resilience in the Americas, and to all the colleagues that have joined us. We ran out of time, so we'll proceed to the closing remarks, and I'll give the floor to my esteemed colleague, Marianne Urbina, advisor in the Country and South Cooperation Office in the Pan American Health Organization at headquarters. I am Alex Camacho, Disaster Risk Reduction Unit Chief at the Pan American Health Organization, and it was a pleasure to be today with you. Thank you so much, Marianne. Over to you, and thank you, Piedad, for all your support. Over.
Thank you, Alex. So do we go for the quiz? After listening to all the panelists, we would like to end with a mini quiz before the final closing remarks of the session. So please take your cell phones, and we will use Slido again for this mini quiz that will cover both parts of the session. So we'll have one question for each. We will project on the screen the QR code and the 2 questions. The questions are multi-choice, so you have to select the answer that you think is more appropriate. So the first question is that's not, when planning for emergencies and crises. No, that's not a question, right? When planning for emergencies and crises, whose accessibility needs must be part of the plan? Patients only, hospital personnel, or family visitors, or all those groups? Correct. So the answer is all of these groups should be taken into consideration. Perfect. So then we'll move to the second question. Which of the following conditions should be met to ensure resilient health infrastructure systems for older persons and people with disabilities? An accessible transport system to ensure older and people with disabilities are able to reach hospitals. Hospitals are equipped to provide healthcare services at the doorstep of older persons and people with disabilities. Provision of power backup for charging of electric wheelchair, hearing aids, and medical assistant devices, and all of the above. Correct again, so all of the above. So meeting all these conditions will help to create a comprehensive and supportive health infrastructure that caters the needs of older persons and people with disabilities. So, well, thank you very much for that. I hope that was helpful. We have also tried to answer other questions in the Q&A. And since we are running out of time, I'm going then to pass the floor to Piedad Huerta. She's the head of the Office of Country and Regional Coordination in PAHO WHO. So Piedad, the floor is yours.
Thank you very much, Marianne and Alex. I would like to thank all of our panelists and participants in this session today. Also, our moderators and facilitators, as well as our interpreters. Thank you so much. We have heard crucial reflections on how disasters and health emergencies disproportionately impact people with disabilities and older adults, as well as the reasons why this occurs. Now, let us focus on how to translate these discussions into concrete and sustainable actions. If we want safe, resilient, and inclusive urban environments, we must integrate older people as key actors in disaster risk reduction. It is not just about protecting them, it is about recognizing their experience, knowledge, and capacities for risk management, consulting them, and making their participation sustainable as an effort to ensure that risk management strategies actively include them from design to implementation. Make it clear that this is not an issue of social assistance, but of human rights and community resilience. The design and management of critical infrastructure can no longer ignore the reality of an aging population. Inclusion in urban environments must go beyond basic accessibility, such as counting with safe and resilient hospitals and health facilities, capable of responding to emergencies and adapted to the needs of all people. Housing, transportation, and routes to and from health facilities designed under a universal accessibility approach, ensuring safety and autonomy. Safe and accessible public spaces that promote mobility, health, and well-being. What we are discussing today must be translated into sustainable policies, financing, and focused interventions. Involve other people and in strategic planning and emergency response. Strengthen governance and intersectoral coordination to integrate inclusive approaches to risk management. Ensure investments in resilient critical infrastructure with accessibility and sustainability criteria. Let's promote cooperation and the exchange of experiences and information between countries and between our cities. Let's learn from good practices, share innovative solutions, and strengthen collaborative networks. Colleagues, no city, no country can address these challenges alone. Please, let's work together. Thank you.
Thank you very much. Oops, sorry.
Please go ahead, Marian. Over to you. Wrap up.
Thank you very much, Piedad, for highlighting some important key message of the session and also for suggesting ways on how to transform these ideas into concrete action. So thank you so much. We will then finish the session introducing you to the third and last session of this training that will be held next Wednesday, 26 March at the same time as today. So the third session will focus on a very interesting topic, leveraging technological innovation for urban disaster reduction and management. And the session will be led by the United Nations Office for South-South Cooperation. We would like to remind you that in principle, you are required to participate to the 3 sessions of the training and respond to the post-training evaluation to receive your certificate. Due to the limited capacity of our platform, some participants were not able to join the first session. We have received some requests from some of you to have some flexibility and see if those are registered would have a chance, a possibility to complete the certificate. So we are going to explore the different options, and we'll let you know in more detail in next session how we could proceed. But in the meantime, you can access all the materials and recordings in the link that you have on the screen. And well, so thank you. And let me show you again in more detail the program of the next session. Yes, you can see the speakers that will be introducing the different aspects of the session on leveraging technological innovation for urban disaster risk reduction and management. So thank you very much again, and we look forward to seeing you next Wednesday. Thank you.
Thank you. Bye. Thank you to all our interpreters and also to our team in PAHO. Thank you. Thank you so much.